about Facebook updates. I'm on the Facebook group. I see all of Jean's photos. She's like, and, following her on Instagram, and Sean emails me. So thank you for all that you guys have, all the hard work that you guys have put in. In the past, when I came back to speak, I think I talked about admission requirements, what it was like to go through, the PT school application and things like that. And then I talked about my first year of school when I was a first-year student. But now that I'm kind of like done and I'm at the very, very last bit of towards the finish line, I decided that it'd be interesting to talk about my clinical rotation experience, since that's a really big chunk of the PT school curriculum. And also I think it'd be interesting to kind of get a perspective through a student perspective versus, Dr. Sherman or someone else who is a professor or faculty member. All right. So I wanted to start with UNLV's DPT program requirements. Every school does things a little bit differently, but more or less it's about the same. But UNLV's program, they require each student to complete 4 clinical rotations. And these are your DPT courses 761 through 764. 761, you take your very first, at the end of your first year of your first term in school, and that's usually during the summer. That's the shortest one, so it's 6 weeks long. And then you go back to school for another full year for your second year, and then you register for 762 and 763. Starting with 762 through 764, those are considered your long-term clinicals. Even though you're registering for 762 and 763 in the fall term, you actually start 762 in the summer. So after you finish your summer classes in the summer of your second year, you actually start 762. And they're 11 weeks and 10.5 weeks respectively, and then the very last one, you register regularly in the spring term. It's 12 weeks long, and you start it in January. Another part of UNLV's TPT program is that they require each student to complete each one of their rotations in one of these settings. The first one is, and you can do these in any order. They don't restrict you, which order you need to do them in. So the first one is rural or underserved setting. Rural is anywhere from a small town population, anywhere from like Elko or Winnemucca, Nevada, St. George. But underserved population is considered any military branch and the pediatric population. Acute care is more like a large hospital base, so anything like Sunrise or Mountain View Hospital, St. Rose. Inpatient rehab is where things get a little confusing. So inpatient rehab, you get a rehab hospital, a skilled nursing facility, a SNF, or a long-term acute care facility, or called an LTAC. A lot of the large hospitals now actually have their own rehab floors, so a patient who gets admitted for acute care, they stay there for 3 or 5 days, they get discharged to maybe, they stay at Sunrise Hospital, but they go down to the rehab floors and they stay there a little bit longer. Rehab, the patients have to be able to tolerate 3 hours of therapy every day, whether it be a combination of speech therapy, PT, OT, or some kind of combination between those 3 disciplines. The difference with the SNF and the LTAC, SNFs, so they get discharged from the large hospital, the acute care hospital, they go to a SNF. The SNF, usually they may or may not be able to tolerate 3 hours of therapy. And they usually stay there a little bit longer than they would at a rehab facility, so they might extend their stay to maybe over 14 weeks. And they're not quite as medically complex as the patients who would get admitted to an LTAC. LTAC, the patients are a little more medically unstable, and they need a little bit more care in that sense, and they're definitely not going to tolerate 3 hours of therapy. So it kind of varies, and their stay usually anywhere from 25 days to over a month. So that's kind of weird. But at least you get a variety of, I guess, different places to go to that would satisfy the inpatient rehab requirement. And then the last one is the outpatient, which we're all, I think, familiar with. These are your outpatient clinics and, the private practices. And a lot of the times the PTs who own the private practices, they also do home health. In home health, you typically travel to the patient's home and then you do the therapy session with them. I'm going to walk back and forth. All right, so my very first rotation over the summer after my first year of school, I did it at Michael local here in town. It's up north at the Nellis Air Force Base. And this picture was taken during some kind of ceremony. I don't remember which one. I think they were like changing over like the chief commander for like all the medical division over at the Air Force, and I think she was a podiatrist. And then this satisfied my underserved setting. I didn't want to relocate to a rural area, and I just wanted to stay here in town. You actually don't take the pediatric course in the UNLV PT program until the spring semester of your second year of school. So even though I had some classmates that did pediatrics for their first rotation, I personally felt like I wasn't prepared, like it was just going to be too overwhelming for me. So I was like, all right, military sounds pretty cool. And I was really lucky that I got accepted because there was actually a few years in between me and the last student that they took, just due to all the CIs being deployed overseas and whatnot. So I was really grateful that they took me in for 6 weeks. So the patient population that I saw at the base, not everyone was active duty, but most were. Some were retired veterans, and then we also treated their families as well. So husband and wives, children, not too many children. They usually try to refer the kids to like a more pediatric specific clinic. It was an outpatient orthopedic setting, and occasionally we would see a couple of other military branches. So through the military, what's interesting is that sometimes there will be like a naval officer or someone like kind of just stationed out here temporarily. If they need medical care, they're actually required to go to the nearest military base facility. And that kind of makes sense. You know, you're not going to make them travel like thousands of miles to get health care or something. So occasionally we would see, maybe people from the Navy or the Army, but usually the majority of them were Air Force. I saw a lot of post-surgical conditions, so anything from ACL reconstruction, there was a lot of. And then some back surgeries, but usually those were more of the retirees, the veterans who gave them back pain and opt for surgery. Some knee replacements of the sorts, but mostly were ACL reconstruction, which was due to the next point were work-related injuries. As you can guess, in the military, you have to be physically fit, and they have physical fitness testing every so often. I think it's like every few months or so. So a lot of times the work-related injuries is, they've been training hard, they've been working hard, and then they sprained an ankle or something. Or I remember one patient came in and he hadn't been keeping up with his physical fitness, and so he had the exam coming up in a couple weeks, and then he started increasing his running schedule. He went from not running at all to like running like 5 miles, and then he's like, yeah, my leg hurts, I don't know why, and I'm like, okay. So another neat thing that I saw there, this was the first place that I actually observed surgery. My CI asked me if I was interested in just spending like half a day there, and I was like, yeah, absolutely. And the nice thing about being at an outpatient clinic based inside of a hospital is that you do have those opportunities to go observe surgery, and I highly recommend that if any of you have that opportunity to take up on it, because being a student is the only time that you get to explore and just kind of see these type of things, because when you're a PT, you can't be like, hey boss, can I just take the day off work and just go watch some surgeries, it's like someone else can take care of my patients, you can't do that. So the 2 surgeries that I saw, the first one was arthroscopic repair of a rotator cuff. That one wasn't quite as interesting. As you'll come to find out, I like bloody, gory stuff. So that one, they just made like really small incisions in the arm, and then they go through with the scope, and then they have it projected kind of like on the small computer screen. But it was still really interesting to see how much it magnified the muscles. The surgeon, thankfully, was pretty nice. He kind of walked me through what he was doing, because I had no idea what he was cutting up. He's like, okay, this is the porcoid process here. I'm like, okay, yeah. But it was really cool. Super cold. If you ever observe surgery, be prepared for that. Super, super cold, and you're not going to sit. I think I was standing 5 to 6 hours straight for the entire 2 surgeries, and they just bring them right in. The other one that I thought was cooler, because it was bloodier, was a ankle fracture, and it was a distal tib fib fracture. And let me tell you, orthopedic surgery is exactly what they say when they say it's like carpentry, because they busted out things that I'm like, did you guys get these from Home Depot? It's like screws and metal plates, and it was just, all right, here we go, hacking away that metal plate and those nails. Oh, hammer's not working, take out the drill and start drilling. And I was like, okay. So that was really, really cool. So I highly recommend observing surgery if you have the chance. This was my CI, Major Lions. Some of the challenges and advantages in this setting for me was, I was actually surprised to see how some patients were actually pretty low. They had a low level of motivation. I was thinking, military, everyone's fit, and everyone's like driven to, stay fit. But there was actually a handful of patients that, they were getting ready to retire. They were more of the older patients. And they were, it's hard to motivate them, they're just they're getting ready to retire. They kind of want to just see if they can find an early way out, So trying to get those patients motivated to do what you need them to do is a little difficult. And in any orthopedic setting, musculoskeletal, having a strong musculoskeletal foundation is crucial. All the special tests that you guys learn in SIM 386, you guys will learn them all again and probably learn a couple new ones when you get to PT school. So don't worry, if you forgot it, you'll learn them again, and if you know it, you'll learn them again, because you will use them a lot. And then, of course, if you do decide that you want to do military, you'll have to consider relocation and also deployment overseas. However, being in the military, being a military PT versus a civilian PT does give you a little bit more autonomy. PTs in the military are able to order diagnostic tests such as x-rays or CTs and things like that. I remember me and my CI, we saw a patient where we were just like, okay, all the signs are pointing to possibly a fracture. And so, we ordered an x-ray for him. And PTs in the military are also able to order some medications. It's not quite as big of the scope as like a physician is, but I believe they can prescribe certain stuff like, maybe ibuprofen, certain things like that. And then also, with a doctorate degree, you enter the military as a captain, so pretty high rank. All right, any questions so far? No?
Why didn't they give you a uniform?
Why did they give me a uniform? I'm actually thankful that they didn't give me a uniform. And yeah, when you go to the military base, like everyone wears uniform. It's usually, they kind of wear that outfit, and then I forgot what day it was. I think it was either Tuesday or Wednesday. It was Blues Day where they wore the fancier outfit, and that's their fancy outfit for like, all spiffy up and yeah. And then I just wear business casual. All right. So my second rotation was at Mountain View Hospital. That's where I met and actually was to observe there. I did this the summer after my full second year of school. So this is just kind of Northwest Vegas. I don't know how many of you guys are from here, but that's where I did my acute rotation. So I'm that kind of girl that likes all the blood and guts and gory blood and stuff. So when I talked to Dr. Sherman about requesting an acute care setting, I told her, I was like, wherever you place me, I want wound care. Like, I want a lot of it. And so they found a place for me. Mountain View actually has their own wound care team, and it's made up of physical therapists only. And I really liked how they have it set up there, because not all hospitals actually have PTs doing wound care. Sometimes it's nurses, and PTs don't do wound care at all, depending on the hospital. But Mountain View actually has a wound care team, all PTs, super cool, because they actually kind of made the orders and the decisions. So the physician would be, they write in the order and say, wound care team eval on this patient. PTs go in, do the evaluation. But what was cool about it is that after the evaluation, the PTs would make the recommendations to the nurses, who the nurses would actually have to follow. So we would decide, is this a wound that we need to come back and see every day? Or is this something that nursing can take care of? And if so, what do they need to do in order to address it? So I thought that was really neat. It was just a very nice system that they had going. And my group research project is actually on a wound care tool, a pressure ulcer staging tool. cool that I actually got to use at Mountain View, so it was kind of cool to see it live in action. So I did a lot of wound care there. Oh, I have 2 wound care stories. I'm going to have a lot of good stories to share with you guys. I'll probably get to the next one. Hope you guys, it's not super gory, but hope you guys can have a tough stomach for it. I also did a little bit of ICU in the acute setting, and I saw, a lot of post-surgery conditions, anything cardiopulmonary. There was a lot of coronary artery bypass grafts, just due to heart disease, especially in the older patients. A lot of musculoskeletal, so a lot, anywhere between 40 to 60 years old, they start to get back pains, and then they go for laminectomies, and they get fusions in their neck. And then some neuromuscular, there was, I think, maybe 1 CVA that I saw. That Mountain View. That was acute. It wasn't like an old CVA, and then they had some other problem. And the thing to note about acute care setting is that the medical care that the patients are receiving are higher, and the rehabilitative care is a lower level. So the PT that you're doing with the patients in acute care setting is, you're not doing plyometrics with them, obviously. You're not running up and down the stairs. It's really basic stuff. It's, okay, let's do some bed mobility. I want to see if you're able to get in and out of bed, roll side to side. When you're in bed, maybe doing some quad sets, heel slides, ankle pumps, real nice, easy stuff. Are you able to, walk over to the toilet? Do you need an assistant? Toilet transfers, gait training, and then occasionally, depending on the patient's living environment, you do some stair training with them. But your role as a PT in the acute care setting is to try to get the patient home. So you do whatever you can to help them meet those requirements so that they can get home. So you're not working on agility per se, but you just want to get them home. So can they walk 150 feet, safely so that they can go home? Can they get in and out of bed, and especially if they're living by themselves? Can they do that? Otherwise, they have to get discharged to a rehab hospital or a STEM or something. All right, you guys ready? Okay. So, the first picture over here, that is a venous stasis dermatitis. These aren't like real patients. I just found them on Google. These were this is my favorite type of wound treat. Like, I love this. I ended up having a nickname by the end of my rotation. They called me the picker. I'm the type of person where if I have a scab or anything, I will pick at it. And yeah, so have you guys heard of venous stasis? Or Dr. Young came in and talked to you guys earlier this year. No?
He kind of glanced over a whole lot of stuff.
Okay. So just in general, venous stasis is usually, they have some type of pathology where their lymph system isn't working properly, so the lymph fluid in their tissues are being transported back into the lymph system. So everything just kind of pulls in their legs because the legs are the most dependent part of the body, so gravity just kind of pulls everything. Over time, as it gets worse and worse, and people don't know about it or don't do anything about it, it just collects in your legs. And so you have all this buildup interstitial fluid between the tissue that has no place to go, so eventually it starts oozing. And it's basically a chronic problem that it's like if you don't take care of it, it gets like that. And then when you take care of it, it gets better, but then if you, again, it's like this kind of vicious cycle, so you have to be really on top of taking care of it. I was less excited when they called the wound care eval, and then they were like, venous stasis. I'm like, yes, and then I'm like, oh, nothing to pick. And then I was like, oh yeah, as soon as I unwrapped the bandages, I was like, the crustier it is, the better. So usually this is what it looks like. So usually that's like all the fluid that kind of oozes out, and then over time it just dries up and becomes like really scaly, kind of reptile, flaky, yellow, crusty. Man, is it satisfying to pick off. And I know, I'm like having like this creepy like smile on my face right now. What I really like about wound care is that you see relatively immediate results. So, this is what it looks like, and then afterwards you pick off what you can, and then you wipe it down with a wound cleanser or sterile saline, and it's like, wow, it looks 10 times better. Of course, there are times too, I remember there was one patient that had like to pick off. And I was just going at it, and then my CI was like, okay, we gotta go see the next patient. I was like, oh, dang. So you won't always be able to get everything off at the same time, but man, I could keep going. This one here was by far the coolest student I saw. So there was a gentleman at the beginning of my rotation that got a cabbage heart surgery, open heart surgery. He was doing well. We started seeing him in the ICU. We started walking him, doing gait training with him. And then all of a sudden one day, we got a wound care referral to go evaluate his wound. What had happened was a lot of the open heart surgeries, now they use what are called sternal talons. And they're basically these metal clamps that the surgeons use to help close up the sternum and hold the rib cage together after the open heart surgery. In addition to the traditional method, which is using just metal wires and kind of wiring everything together. Well, he was a big dude. He was a very, very big dude, and the talon and the wires just busted. So they took him into the emergency, OR, obviously. They had to remove everything immediately, but because he was so unstable, they couldn't close him back up right away. You were just kind of like, okay, let's just get this thing out of him. He was vented. So he went from walking around in the ICU to being vented, and then my CI and I came in and saw this. The surgeons had placed it. Dr. Young talked to you guys about wound vacs?
Yeah.
Kind of, yes. So the surgeon had placed a wound vac on there, and it was the scariest thing for my CI and I because the foam that they used was the silver foam, which is when you peel it off, it tends to take a little bit more tissue with it. They're supposed to use the white foam, which is more dense and it doesn't damage things as much. And that's what you learn in school, but then the surgeon goes and does something different. So you're like, okay. So instead of putting the white foam to protect the organs, which is what they're taught, what we're taught in school, they put a silver foam, which has the antibacterial properties. But after we finally took off the silver foam that was just kind of there, the surgeon only had left a skin flap, and I could see the heart pumping. And I could see the edges of the sternum, the bone is just all kind of cut up, like very neat. There's just, and then at one point I was like, just pulled the piece of bone and just tossed it out like a fragment from the sternum. So, and the orders was to put a silver foam back in until he's ready to go back into the OR to be closed up. So, my C and I followed orders, we put it in, and then literally, I think towards the end of the day, we get a call back from nursing saying we need to go back up there. We're like, why? Usually a wound vac check is due to a leakage, like there's an air leakage or something clotted somewhere where it's not suctioning correctly. So we go back in. I'm sorry if any of you like strawberry cherry jello, but we couldn't see the foam anymore. All I saw on the top layer was this gelatinous dark red jiggly. His blood had clotted. His blood clotted instantaneously. It blocked the wound vac. So peeled it off, started hacking away at jello chunks, and put in a new wound vac. And we're like, okay, we really hope this guy goes back to the OR and they close him up because we can't do this wound vac change any longer. It's just the scariest thing anytime a wound vac is over or near, especially an organ like the heart. So those were my two cool wound care stories. The challenges in the acute care setting, the untold dark side of PT, I have another story to tell. So in school, they say, okay, well, if the patient pooped, nurses wiped it up. It's not really a job description of PTs. You're going to have to wipe a lot of poop. Care. And I'm pretty much desensitized to it now, so I apologize if I gross any of you guys out. And I apologize too for this next story coming up for the vulgar language, but it's a direct quote from my patient. So one time there was this patient that my CA and I saw right before lunch. Really stoic guy, did not talk, no facial expression, just hated life kind of thing, So we're like, okay, well, he's in bed for a long time. We should sit him up at least so that he can have his lunch. And then after we have our lunch, we can come back, put him back to bed. Because usually by then they can only last a few hours before they get tired and want to go back to bed. Well, this gentleman, he wasn't super big our body's safe too. My CA and I went to go get a machine called a stander. It's basically this machine where it kind of has like a harness to kind of look up underneath them, and then it kind of has like this metal brace in front, and you hook it up to the harness, and it basically lifts up the patient, and then you turn it because it has wheels, and then you turn them wherever you want to go, and they're being supported the whole time by the harness. So then, we're like, okay, we'll just use that. So it worked fine. Well, we came back after lunch, and a lot of the patients in acute care, they don't have anything on them. It's just a gown. They're completely naked. He hasn't said a word to us at all the entire morning session while we were doing ankle pumps. We're just like, okay, can you do 10 sets of ankle pumps? He just did them, didn't say a word. So we stood him up to get him back to bed, and we just pulled him up from the chair, rotated the stander over towards the bed, but hadn't quite reached it yet. And then that's when he opened his mouth and said something. And he said, so picture an older gentleman like this, strapped up, and then he goes, I need to take a shit. I was like, so everything just like froze for me. Like everything just froze. Because I was like in my head, I was like, it's kind of like the movies, when like everything just kind of comes to stop, and it feels like the longest time in your life, but really it was like half a second or something. So all the patients that I've seen, it was like, oh, I need to have a bowel movement, I need to use the restroom. And so I'm standing, I'm like, do you really just say what I thought you did? And literally, as soon as my thought was completed in my head, fecal matter explosion onto the floor. Explosion, and I am not exaggerating, it was an explosion. And my CI was like, well, timing couldn't have been better. I was like, yeah. And I have no idea how my CI and I were able to keep a straight face the entire time. Like I said, once you kind of just do it so much, you become desensitized. You just kind of, okay, well, we gotta keep them up, get them a clean gown, get them back to bed, tell nursing what happened. And then finally, when all that was done, I'm sitting at the nurse's station typing up the documenting the note for the treatment session. I'm just like, okay, I gotta stop laughing. People think I'm crazy. But yeah, you're gonna have to wipe a lot of food. There's something they don't tell you. It's not part of your job description as a PT, but a lot of times the nurses are so busy because they have 5 or 6 patients. They gotta get their meds. They gotta do doctor's orders. If you roll a patient over, they had an incontinent episode. Why it's not something it's not like taking out an IV where you actually need the nurse's help. It's you just wipe it up, because usually in the acute care setting you don't see a patient more than maybe 25 minutes at the most. So a lot of times if you wait for nursing to come, by the time they get there and clean it up, you're not going to have any time to work with the patient. So it's just better to just wipe it and go, and then carry on with gait training or whatever it is. In the acute care setting, transfers, you're going to have to do a lot of transfers. Like, with this patient, there are machines that, things that can help you, but be ready for heavy lifting. And then the intensive care unit can be a little bit intimidating just because of all the lines and wires, so you just got to be kind of careful. And then talking with the staff, you're going to have to talk with the nurses a lot, especially if you work in ICU, because the patient's conditions is always fluctuating. Let's see what else. But you're going to see a huge variety of patients all over. Anything you can think of. Like, some of them are actually seriously crazy. You're just like, whoa. And then I like to wound care a lot just because it kind of mix things up a little bit. So how the schedule worked at Melody was me and my CA, we would do regular PT, if you will, on most days, but maybe 1 or 2 days out of the week we would do wound care. So it kind of changed things up a bit, and we would rotate with the other wound care PTs. And the schedule is very flexible. Like I mentioned, you'll see a patient typically anywhere from 15 to 25 minutes if you're just treating them. But if you're evaluating them for the first time, obviously it's going to take a little bit longer, maybe 30 minutes or so. But you make up your own schedule. So in the morning, the lead PT will kind of have a assigned stack of patients for all the other PTs. And you would just pick up your stack, kind of go see where you're at, what tower, what floor, and you would just kind of go about, okay, this patient needs transfer training or he needs gait training, let's do 23 minutes of it. So whether you want to do your documentation after each patient, which was what I preferred, or some PTs waited till the very end of the day to document all the patients that they see. So, any questions? Did I rush you guys out with food? Alright, so my third one was at Desert Canyon, and Vicki came in last fall. I was here when she presented. She was my CI. Had a very, very good experience for my rehab. And Health South Desert Canyon actually got voted by Review Journal as the top mid-sized corporation, like as top workplaces to work at, so that's pretty cool. Patient population, more or less, post-surgical, but I saw a lot of TBI, I saw a lot more CVAs, I saw my first couple patients with amputations. Old people are cool, I really like old people a lot. And then, your back surgeries and whatnot. This was the setting that gave me that moment of tears of like, oh my gosh, this is why I'm here. There was a patient, older gentleman, early 40s, had a motor vehicle accident and got a TBI from it. Has a 4-year-old son. Had to leave his son and girlfriend in California to come here for treatment. Mom was about 60. And it was about 1.5 to 2 years since his motor vehicle accident when we saw him. And when he was down in California, he basically didn't get the right treatment. They teach you in school neuroplasticity and neurophys, where the brain has the ability, during that kind of open window, right after an injury where they're stabilized, that's like the perfect time to do therapy, because you can actually reform those connections in your brain that tells you, okay, this is how you move, this is how you do this. Well, they didn't quite do that with his therapy in California, and so, long story short, he was pretty set back. He was super strong on his uninvolved side. He was a hemiplegic, but yeah, just spastic, a lot of spasticity, really weak. So we were doing gait training with him, and he was doing well. He progressed from the past the parallel bars. We took him out in the hallway and just kind of had him use the railings. And gait training with TBI patients and CVA patients who are hemiplegic, you're going to break out into sweat. Vicki was kind of guarding, sitting on one of those rolling stools, and you're literally facilitating every single movement, because they're almost completely flaccid, if you will. I mean, with him, he had a lot of tone, but it was, all right, you're using every part of your body. It's like, okay, he needs to have heel strike when his foot hits the ground. I don't want him to invert his foot, so I got to block that. I'm using my shoulder to facilitate hip extension. Oh, got to do, quads. A lot of work, but totally rewarding, because TBI patients typically are a little more emotionally labile. They lack judgment. They're a little more impulsive. They kind of don't know what's going on sometimes. So we were doing gait training with him in the hallway, and then all of a sudden he starts crying, and we're just like, what's wrong? We thought something had hurt or whatever. He's like, I don't know. He's like, I'm just crying because I see my mom crying. And what he didn't realize was his mom was watching, just standing off to the side, just crying quietly. And she's just like, I've never seen him make so much progress here just this first week compared to the year he's been in California. So, it was like a very emotional moment. Like, me and Vicki were like trying to hold back her tears. But that was kind of like the moment for me of like, okay, this is why I'm here. This is why I want to do physical therapy. And then similar with CVA patients, very, very rewarding. Sometimes you get more excited than the patient, because they're just kind of like, well, I'm still not able to walk. But you're like, no, you don't understand. You can get your legs straight. Hold yourself up. Like, that's good. Patients with amputations are a lot of fun to treat too. There was one gentleman, older guy, about 70s, fittest 70-year-old I've ever seen. We come in, we evaluate him. We're thinking, why are you even here? He just jumps right up. He rolls in on his wheelchair. He walks with crutches, no problem. He had a below-the-knee amputation due to infection. And everything was easy for him. So every time he comes in, he's like, I want to do the rickshaw. He just goes, and it's like, it's not heavy enough. You're going. Another patient was a double above the knee amputation. That was really cool. And I got to work with him using stubbies, which are prosthetics without the knee joint. So when he stood up, he was probably maybe only this tall. And then, let's see, I remember there was another patient, he was about 30. He also had below the knee amputation, but he was so much fun to work with. They had the Wii over at South Desert Canyon, and so we had him stand on one leg, guarding him, but he'll play Wii bowling, and I'll play with him, and we have like competition and Fruit Ninja. So it was a lot of fun. And then in rehab, there's a lot of technology that you can use. And then specifically at Desert Canyon, they had a pool there, which was nice to do aquatic therapy for some of the patients. But yeah, I really like the rehab setting just because I feel like that's kind of the period where like PT really happens. It's acute care, they're stabilized, you just want to make sure they're medically stable, but then in rehab it's like, okay, this is where we really, really come into play. Challenges, quest for treasure kind of continues. You're going to have to wipe a little bit of poop, not quite as bad as acute care, but just a little bit. Transfers and gait training, I mentioned a lot of heavy lifting, especially with the patients who are hemiplegic or weak. And then here in this setting, you're on a set schedule, so the patients, they get a schedule every day in the morning that says, okay, you go to occupational therapy with this person at this time, PT at this time, and so the nurses get that as well. So you don't necessarily communicate with the nurses quite as often. I mean, you still do, but it's just not as intense as an acute care setting. But the communication with the therapy staff in this setting is super, super important because sometimes PTs, technically, we treat the whole body, but in rehab, you tend to see that OTs treat more of the upper body and PTs do trunk and lower extremity. So sometimes if there's something that you notice in the patient before, sending them to OT is like, hey, I noticed that his knee tends to buckle. So if you ever try to walk him back to his room instead of wheeling him back, make sure, you watch out for that knee. But it's really nice because you get that communication and a lot more reinforcement. So even though we treat in that setting, you kind of do more lower extremity, you can still help the OT reinforce whatever their goals are by doing upper extremity stuff. Varied patient population again, and like I said, huge, huge, huge job satisfaction and the structured schedule. So if you like that structure, you just kind of set times, rehab might be for you. My last one is where Hillary was at, and she left. At Physiotherapy Associates Children's Therapy Center in Henderson. It was an outpatient pediatric clinic. This right here, well, the flyer was a newsletter that I helped the clinic create. So for every rotation, you're required to do an in-service project, kind of as a way to thank the clinic for taking you in as a student and helping you learn and whatnot. And it can be on anything you want. It could be on anything your CI wants. It could be something that the clinic or facility needs. I personally don't like to do the whole research a topic and then do a presentation on it, because I always feel like I'm the dumb one. I'm like, I'm a student. You guys are the PTs. You guys probably know more about this than I do. But and I had to do a couple of those, which I wasn't fond of. So when the clinic director here, Kristen, she was like, well, I've been really busy, but I haven't been able to do, the monthly newsletter that I want to put out or a marketing flyer to the physicians. And I was like, great. I'm like, I actually enjoy doing that stuff. So I got to put together that, and probably by far the best in service because I didn't have to do a presentation. The patient population, we saw a lot of torticollis, a lot of plagiocephaly. Have you guys heard of those terms before? So torticollis is basically crooked neck. In adults, it's called acute wry neck, but in infants and kids, it's typically called torticollis. It's usually shortened muscles. The scalenes, the SCM, and the trap are typically most involved, and usually it's congenital. They're usually born with it, and it's most likely, most of the time, it's due to just positioning in utero, but sometimes it is a nerve injury related. And so the condition that accompanies torticollis typically is plagiocephaly, which is abnormal shape of the skull from external forces. And that kind of makes sense because they're stuck in this position the whole time. Anytime they're laying down or whatnot, it's that part of the skull is going to get flattened. We saw a lot of kids with cerebral palsy, and cerebral palsy, it took me like 7 years to finally understand what it was, because I'm always like, do I just not know what cerebral palsy is? So cerebral palsy is like an umbrella term of just motor deficits. Two kids can have cerebral palsy, but their presentation will be completely different. And a lot of the times in pediatric clinic or setting, you'll see delayed milestones. So, my baby is 6 months, he's not able to sit up by himself yet. What can we do? Down syndrome, there were quite a few, and then other genetic disorders like Danny Walker syndrome, which is a genetic condition affecting the cerebellum. I did see a little 8-year-old girl who had Arnold-Chiari malformation and actually had to get surgery, and she actually had her neck fused, like 2 of her vertebrae fused at age 8. Some of the challenges, I can see why pediatrics is an underserved setting. It's super, super, super tough. Because these are little kids, you can't tell them, all right, Jason, I want you to take that red TheraBand and do 3 sets of hamstring curls for me. They're not going to do that for you. And you're like, what? See ya. So you have to be really creative. You have to take adult activities or exercises and adapt them to for a kid. And a lot of the things that you do too, you're not going to do hamstring curls. You're not going to do long arm quads. You're not going to, if you want to strengthen quads, you get a toy, kind of feel bad, it's like a puppy almost. But you put it up there, and then you get them to stand up, do sit-to-stands over and over for strengthening, If you do hopping, hopscotch, or climbing upstairs on the, to go down the slide for strengthening, different things like that. So you have to be really creative. Talking with parents and families can be a little bit intimidating. And it's understandable, the kids have been through a lot, they've been through a lot with their kids, and, it's understandable that they're very protective, and sometimes they can be very, very concerned. In peds, there's a very, very high cancellation rate, because, kids get sick all the time. And the bad thing about that, too, is if a kid is progressing, usually if they get something like even just an ear infection, can totally set them back. So if they were able to stand and take a few steps after their ear infection, they might not be able to. It's just got to start from square one again. The schedule is a lot less structured because of the cancellations, and also because they're kids. They have moods too. One day they're just like, I'm just not going to do it. What are you going to do? So for me, being more structured, I think that was a little challenging to deal with. And also with kids, much slower progress. With adults, when you develop goals and plan of care for them, your short-term goals will be anywhere from 3 to 4 weeks or something, and then long-term will be like 6 to 8. Kids, short-term goals are typically 6 to 8 months, and then long-term is anywhere from 12 to 14 months. Advantages, you get to be called Miss Bagus. So I had a 5-year-old patient, my CEO was talking to me, he was like, oh, so do you remember my friend's name? It starts with an F. And he's like, oh yeah. I was like, how? I was like, this is the first kid that remembers my name, because every kid that they're like, what's your name? I'm like, Miss Faustina. They're like, it's weird. And so he's like, oh yeah, I totally know. We're like, oh yeah, what is it? He's like, Miss Bagus. He was very comedy. He's like, yep, that's it. And I was just like, all right. This here was a Valentine's card and little gift that one of my, I'm trying to remember, he was 7-year-old patient gave that to me during Valentine's Day. So it's very sweet, very heartwarming. So there is a lot of job satisfaction. If you like to talk a lot and educate, patient education is huge in pediatrics, more so than I feel like any of the other populations, just because a lot of times it seems like common sense stuff, but the baby tends to prefer to this position. Well, you tell the mom well, when you feed them, how about it's a lot of education on what the parents can do, and then just they're kids, they're cute. They drool, they pick their nose, they throw up their milk, but they're fun, they're cute. And that is the end. So that's me. So this was at the end of first year of PT school. In functional training, Dr. Young taught it. We were learning wheelchairs and walkers, and it was in the spring semester. And it also happened to be in March, so my class was doing that March mustache thing, and all the guys started growing out the beards, and then the girls bought like fake mustaches, but a lot of the girls in my class are blonde, so they were like, "Oh, Faustina, this would totally look real on you." So they like tied up my hair, and so that was what it was. Yeah. So, but are there any questions that you guys have? Just right on time. Sure.
What type of setting do you picture yourself working in?
My top 3 is acute care, so wound care, and you have the best stories, seriously. Like the poop story, like I tell it all the time, like over dinner too. I really like acute, and then I like to rehab a lot, and I also, if I do outpatient, I see myself in peds outpatient. So any of those top 3, and I think that's the best part about PT is you can just kind of, if you change your mind, go do something different. There's plenty of stuff. So
You were talking about lack of motivation with like military patients and sometimes in children. So what did you do personally into like motivating them to actually work?
I think with patients, from day one when you meet them, I think I always try to go with the approach of just getting to know them on like a more personal level, just kind of having casual conversation, and they are usually kind of not aware, but what my goal is to find out what they like so I can use it in my advantage. So it's like, oh, well, I really like tennis. I was like, really? Okay, yeah, well, it's like, you're not going to be able to play tennis on that leg. I mean, you don't say it like that per se, but just trying to get to know them and figure out what they like. Same thing with little kids, usually when they come into the clinic, they usually have a toy that they really like to play with. So you typically try to use that toy or just something that's motivating for them that they enjoy.
I come from a military family, and so I kind of know how regimented those folks can be. But I was wondering, did you find that population was more receptive kind of to how regimented PT can be sometimes compared to other settings, or was it really all that different? Does that make sense?
Right, you're saying like, were they more receptive of doing exercises?
Yeah.
And I think it varies. I want to say maybe a little bit more receptive compared to your average population, because like you said, them being in the military, they know that they need to train, do all the physical training. But there were a couple that, the older folks are just kind of like, they're like, well, I'm overweight already. Now I'm going to retire. Why do I need to walk? It's like, so it kind of varies. Any other questions? All right. Well, if you guys have any questions in the meantime, feel free to email me at either of those emails. They can work. But thank you again for letting me come in and speak, and congratulations to all of you who are graduating.